Olá, muito bom dia mais uma vez. O meu nome é Manuela Lourenço Marques e eu sou a Presidente da Associação Nacional de Doentes Linfáticos. Estou aqui com a professora Joana Ferreira, da Sociedade Portuguesa de Angiologia e Cirurgia Vascular, e estamos em conjunto para darmos início a uma série de webinars sobre o tema Linfedema, Partilhando Experiências. Devo referir que estou particularmente feliz por ter connosco os nossos oradores e moderadores, e quero dar aqui um cumprimento especial a duas pessoas com quem tenho estado a trabalhar na Europa, o Dr. Damstra e a minha colega Eline. Lamentamos porque no momento... Ops, estamos mesmo com problemas técnicos. Peço desculpa, mas alguma coisa aconteceu. Vamos outra vez. Estava eu a dizer que lamentamos por não ter sido possível encontrar um sistema de tradução, mas a nossa assistência é realmente bastante grande e temos tido a oportunidade de sentir o interesse por esta temática. Este webinar está a ser gravado e qualquer questão pode ser colocada no chat. As informações fornecidas neste webinar não se destinam a substituir qualquer orientação do seu profissional de saúde. Os doentes devem sempre consultar o seu médico e é ele, e apenas ele, que poderá dar alguma orientação. Estou profundamente convicta que não estamos sozinhos e que trilhamos o nosso caminho sempre em conjunto. A partilha é a única maneira de ficarmos mais ricos. Hoje iniciamos uma troca de experiências entre o que acontece na área do linfedema no nosso país e também iniciamos, quem sabe, um caminho não só na Europa, mas também no mundo. A Holanda e a sua experiência na área do linfedema é o início desta viagem, mas já em setembro iremos até à Dinamarca, sempre viajando na área do linfedema e sempre partilhando as nossas experiências. Estamos no mês do linfedema e no dia 6 de março todas as vozes no mundo se uniram à volta desta doença ainda tão pouco conhecida. Estamos a divulgá-la, estamos a chamar a atenção e na Europa, juntamente com os nossos colegas, elaboramos portanto, um manifesto onde apontamos para as nossas principais dificuldades e as nossas ações. A Associação Nacional de Doentes Linfáticos em Portugal tem trabalhado não só na área do linfedema e do lipedema, mas também das vasculares raras e em conjunto tem vindo a promover a literacia. Aproveito para chamar a atenção que muito brevemente iremos ter o primeiro encontro de doentes com vasculares raras, pais e crianças, e portanto se têm nos vossos consultórios alguma criança, alguma família com esta particularidade de vascular rara, por favor contactem-nos. Já na segunda-feira iremos também ter um novo webinar sobre o linfedema nos membros inferiores e, portanto, estejam atentos que iremos, de certeza, adquirir mais conhecimentos e melhor forma de tratar o nosso linfedema. A Associação conta com um conselho consultivo, dado que acredita profundamente que a informação correta é aquela que deve ser dada ao doente e a informação correta vem sempre dos profissionais que a estudam e aprofundam e a partilham com cada um de nós. Portanto, a Associação é uma associação que está no mundo, com os pais, com as famílias, com os amigos e não está, de certeza, sozinha, trazendo para Portugal todos os conhecimentos. Mas, sem mais demoras, eu irei passar a palavra à minha colega de painel, a doutora Joana Ferreira, para apresentar-se à sociedade e o seu trabalho.
Muito bom dia a todos. Muito obrigada por estarem cá. Eu chamo Joana Ferreira, sou médica de cirurgia vascular. Neste momento também sou a coordenadora do Núcleo de Anomalias Vasculares Congénitas e Cirurgia Vascular Pediátrica e, como tal, eu faço parte da Sociedade Portuguesa de Angiologia e Cirurgia Vascular. E para quem não sabe o que é a Sociedade Portuguesa de Angiologia e Cirurgia Vascular, é uma sociedade científica que visa aumentar a formação dos médicos de cirurgia vascular, de modo a que estes possam prestar um melhor serviço e um melhor tratamento aos seus doentes. E nesse contexto nós não podíamos deixar de nos associar a esta iniciativa e quando a Manuela me convidou, obviamente que eu aceitei e também trouxe aqui para esta iniciativa mais 3 cirurgiões vasculares portugueses. Como a Manuela disse, nós estamos a falar de um conjunto de 3 webinars para este ano. Nós neste webinar vamos partilhar a experiência portuguesa e a experiência da Holanda e no próximo webinar iremos partilhar a experiência da Dinamarca e depois anunciaremos o país seguinte. Aqui a co-moderar comigo esta reunião tenho o Dr. Vitor Ferreira e o Dr. João Vieira, que além de excelentes cirurgiões vasculares do ponto de vista técnico, também o são do ponto de vista humano, o que é particularmente importante quando tratamos doentes. E vou passar a palavra ao Dr. Vitor e ao Dr. João Vieira.
Olá, bom dia a todos. Obrigado pelo convite para participar nesta excelente iniciativa. Eu penso que agora vou passar para o inglês, de forma a incluir aqui os nossos convidados holandeses. So, good morning, everyone. Thank you for the invitation. And I'll introduce the first speaker, Professor Ivone Silva. She's a vascular surgeon from Porto. She was a mentor of mine in my training, and I'm happy to introduce her to speak about epidemiology and quality of life in lymphedema patients. So, welcome, Professor Ivone.
Thank you. Can you tell me if it's seeing the presentation?
Not yet.
Está a aparecer a apresentação?
Não.
Ops, então temos que ir outra vez. Apresentar. Há bocado conseguimos pôr, desta vez já não conseguimos. Só um minuto.
Está a aparecer, sim.
Aparece? Não.
Agora aparece em escuro.
Então não sei. Deixa-me ver outra vez. Que há bocado conseguimos pôr. Apresentar.
Sim. Perfeito.
Já aparece?
Já aparece bem, sim.
Vamos para o grande. Ok. So, voltamos outra vez ao English. Thank you, Joana, for the invitation to be here in this webinar. This is an important theme, especially when regarding patients, and especially on the theme of what I'm going to talk about, which is quality of life. Não tenho acesso aos botões. Podem mudar o slide, por favor? World Health Organization defines quality of life as an individual perception of their position in life, in the context of the culture and value systems in which they live in relation to their goals, expectations, standards, and concerns. The reason why I have put this slide is that quality of life depends on what everyone or every individual thinks of what may be the quality of life. What is for me might not be for you. So this is an important point when we think about quality of life. Next slide, please. Regarding quality of life, we have to think on the different aspects of which we have to think. First, on the health of the people. One of those is about social relationships, of the way the patient sees himself, how the way he managed to be with other people, how the way he can still do the activities he wants, about emotional well-being, which is important. One of the most important aspects, especially in patients with lymphedema, is about the body image. The constraints which coming about not being able to work and all the access which they might have to all the quality and possibilities of treatment. So when we talk about quality of life, we have to think about all these goals. Next slide, please. How do you evaluate quality of life in these patients? We have several ways to do so. Most of them talk about the physical health, the psychological health, the social relationships, and environment and quality of health. This is the World Health Organization table to evaluate quality of life. But regarding lymphedema, we have specific ones. Next slide. We still have the SF36, which all we know when we try to evaluate quality of life in any kind of disease. Next one. But then regarding lymphedema, we have the specific one, which when we try to see what is evaluated is the symptoms of the patient, the body image and appearance, which is extremely important for what? How can the patient work and have this motion? It's all about the function. And also importantly is the mood. What is the psychological impact which it has? Next slide. Just to show that this has been validated for Portuguese, which is very important so that we can use it in our country. Next slide. This is a nice study which tells us that quality of life has nothing to do with the stage of lymphedema. When we think about a patient with lymphedema, we would think that patient who is in stage 2 or 3 maybe would have a worse quality of life than one which is in stage 1. This study has shown that it had nothing to do with the size of the limb, and it has not to do with the stage of which the patient is. So there are a lot of points which we have to be evaluated when we're thinking about quality of our life in these patients. Next slide. This study studied all the kind of questionnaires that are available to study quality of life in patients. And they got to the conclusion that the best ones would be these two, ICF and lymphedema quality of life. As you can see, the one which I have presented before, the one which has been validated for Portuguese, is also here, but he has not been considered one of the best. Next one. In this one, in the ICF questionnaires, you can see which is evaluated is the physical function, the mental function, which is really important. Next slide. The general task household, how people manage their daily life, the mobility. Next slide. And life domains and social life. So this one is probably one of the best questionnaires to regard all the points which we must evaluate when we are talking about quality of life in these patients. Next slide. The other questionnaire is not very different from the SF36. It has a lot of the short and the long one, which we can evaluate, and we can see that the items are very similar to SF, and they also go through all those items which we've been talking about. Next slide. So, how to live with lymphedema, what to do with lymphedema when we're talking about all of these points when we regarding quality of life. Next slide. When we go through what is written, what is in the literature about what the patient think is related to quality of life, we have to think about the functional impairment, about the fear and all the preoccupation about having an infection which goes to worsen the lymphedema, the anxiety of the progression of the disease, depression, which is very strongly associated with the social, with the functional and social impairment. We can't think about the sexual relationship impact that this can have, especially when we're regarding the lower limb, the avoidance of the activities they enjoy because they cannot do them anymore, and also the physical symptoms, which is discomfort and pain, and other aspects regarding the skin quality, which also has a strong impact. So when we try to talk about quality of life, we have to think the way the patient sees it, and these are what we have to look for. Next slide. Also, we have now the PROMs, which are the best way to evaluate quality of life, more than all having all those questionnaires. You try to understand what is the patient-reported outcome measures of quality of life, which is those that really concern the patient. And again, in this study, what has been more important for the patient is the body image, it is the sexual relationship, the limb function, and all the impact it has to do with the social well-being. Next slide. So what can we get when we have patients with lymphedema? We can get a poor quality of life. As we have seen, it is not related strictly with the stage of the disease, we can see that patients complain about worse physical function. They all believe it's an active disease, and they really are very concerned and have a high anxiety levels about the progression of the disease. It has a strong impact on the mood due to the depression, with the impairment of the social impairment also. Most of patients complain about fatigue, and they also say they have a poor sleep related to the disease. Next slide. So for this reason, improving quality of life in these patients must be one of the most important goals in the treatment of lymphedema. And now can we help our patients to do so? Next slide. We have to have a very strong work regarding health literacy. If the patient doesn't understand what is the disease and what he can do to help himself, surely he won't get big improvements. So I believe that health literacy has more and more a great importance in the management of disease, and specifically in lymphedema. They need psychological support. We need training of therapists regarding this disease and working only with these patients. We have to have guidelines for the patients to regarding risk reduction and exercise guidance. And I think, and I believe, I have been part of other patient societies, we have to have an active role of the society, especially with the associations of patients. And we have here the representative of our Portuguese one, which is Dr. Manuela. And it is important to have these societies to help the patients to improve. Next slide. So regarding health literacy, we know it is very important for the empowerment of the patient. So he understands the disease, he can do some self-management, he can look for what it can help him. So in the end, we'll have some promotion of the health for the patient. Next slide. So health literacy in very plain language is the patient being able to understand and take the right actions to make the good health choices. And how can we help the patient to get a better literacy? Try to teach patients, first to tell what is the disease for him to understand, then try to teach the patients how to help themselves to reduce the progression of the disease. Next slide. Having our societies and the different departments where the patients go. We cannot forget about the patients with secondary lymphedema due to surgeries to cancer, especially breast cancer and gynecological cancers, which lead to lower limb and upper limb lymphedema. And we have to have a very close relationship with these patients with good information. Next slide. This is examples of what has been done here in Portugal regarding the upper limb lymphedema after breast cancer surgeries. We've got workshops for the patients. We have webinars for the patients. Next slide. We have this in our society, patient association, the information about the lymphedema. This is about the secondary lymphedema. Next slide. Teaching patients how they can help themselves at home, doing the exercise, for example, to manage the lymphedema and try to reduce the progression of the same. This all has to be given to the patients, otherwise they will not know how to do it. Next slide. Teaching them how to do the compression therapy. It's also important, and we cannot think about it, is how to involve the family to do and help the patients with this. Family has a very important role in trying to help patients to accept the disease and to improve their mood and the social function. Next slide. Then when we get to the other part of the quality is getting access to therapies which the patients need to try to avoid the progression of the disease. And so, next slide. We get to one of the best and most important aspects, which is the financial constraints. I know that Holland has a different way of seeing it. It's not only in the lymphedema, but also in other domains, like in the peripheral arterial disease. It also happens. We don't have it here in Portugal, but I think we have to try to improve this. our patients will lack the financial resources to go to specific clothing and shoes for compression garments, and also to have access to physiotherapy, which is not always available to these patients, and we know how important it is for them to have to avoid the progression of the disease. And we cannot forget that most of these patients also get a very important financial impact due to the decreased or even non-existent ability to work and maintenance of their employment, which also leads to great financial constraints. Next slide. So these are part of the therapies which patients should know they can get and how to get to them. Next one. Also to the compression garments. Next one. Another way, next one. And all the kind of therapy which they can do at their home, and which if they don't have the financial, if they don't have the money, they can't buy this equipment to have at home. And our national health doesn't provide this equipment to have them at home. Next slide. Then we have to have the psychological support. We know that either the upper limb or lower limb can have a very negative impact on the patients and can lead to the isolation from the society, and we must help the patient not to go through this process so it will not occur. Next slide. Never forget about the body image, which has a very important role in the social well-being, and these patients need to be really helped so they don't have this negative body image, they don't have the isolation. Next slide. And they won't have a negative impact in the sexual relationship, which is very important for the well-being of our patients. Next slide. And at last, we have to talk about employment. Most of these patients cannot maintain their jobs, which they have before, and we have to know how can we help them so that they can at least maintain partially the employment that they have. Next one. So this is a study from Canada, the Lymphedema study, and it's quite shocking for the results, which you can see here. We can see that people that are employed are only 3 in the international, compared to Canada to the other ones, only 14%. We can see that most of the patients are only at home. We have also a quarter of the patients which are retired. And we can see on this little round table that we have some which are needing aids for working or even in a wheelchair. So this really has a big impact and can have a strong negative impact on what it is regarding the employment of these patients. Next slide. So literacy, health literacy again has a very important task. Teaching these patients how to manage when they are working, how to have the support to manage to keep their work. And now most of the patients can work. One of the things which is positive for the COVID is to keep work at home, so they can we can avoid the unemployment of these patients. Next slide. On the other side, we know that there's a lot of lack of support. We don't have very specific lymphedema practitioners, which is a big problem. And then when we have those, we also have very big difficulty finding and getting access to them, or having a long-term access to these, because usually you can give 3 months, 6 months access to these practitioners, but then it will end, and so that is not good for the progression of the lymphedema. Next slide. This is an interesting study which was published recently, and it's the evaluation of the prompts. Again, the patient perspective of the improvement of the physical activity and of these patients. It has a big component. It's a 7-week schedule. It had a big component of patient education. Again, I believe that patient education and health literacy is one of the areas which we have to really work hard on these kind of patients. And then we had the part 2, which is a physical activity. At the end of these 7 weeks, the increase of the problems was really big, which means that if we can give this to the patients, we'll really have good outcomes. Next slide. It's just to end as just try to reinforce the work and the role which of these patient associations have, the way that lymphedema patients should know they exist, and this we doctors should tell our patients with lymphedema that there exists these associations so that they can look for support and have tried to improve the quality of lives. Next slide. And that's all, and thank you for the opportunity.
Good morning to all. I'm João Vieira. I'm a vascular surgeon from Portugal. I would like to thank to andLINFA for this invitation to be here and try to learn more about the lymphedema. My task now is to present the next speaker. But first of all, I would like to ask to all the persons that are listening to put their questions in the private chat if they want, of course. So our next speaker, it's a very well-known doctor. It's a dermatologist from the hospital Smelling. It's like that. He rules an expert center of lymphovascular medicine, and he has a PhD. I'm sorry, he has a PhD in that concerned, the diagnostic and therapeutic aspects of lymphedema, and is the founder of the network of the Dutch Lymphedema Network. Is that right? And I present Dr. Robert Damstra for the next speaker. Thank you.
Thank you very much for the invitation, and especially to Manuela, who I know already for a long time, because she's a representative for the patient groups in the PPL, the European Network for Rare Diseases. And the organization asked me to tell a little bit about how the Dutch Lymphedema Network starts and what we do at this moment. And Eline after me is also a member of it and will tell much more. The program what's the history, what's went before, a few reasons for starting a national network. I will tell a little bit about achievements we had through the years, the organization, and last but not least, I think lessons to be learned. Because in Drachten, now it's an expert center for lymphovascular medicine, and we are recognized by the government as the only one in our country. But far before that, we just started out enthusiasm for lymphedema, lipedema, and chronic edema and phlebology, actually, and work together. And I think that is the main line, the red line we always see in the work we do. We work together. And in the picture, you can see when I was much younger, together with physiotherapists, nurses, vascular surgeons, and so on. In that time, we written a book, the first book in Dutch about lymphedema. We made courses for bandagists, medical doctors, nurses, self-management courses for the patients. And we had also brochures for patients who went to our center. And at that time, the internet was, of course, new. And then we bought the name www.lymphedema.nl, which of course felt general, and at that moment it was available for us. And we started to do the same work as we did already in our center, to expand it to the internet, to have facts, questions, and of course to communicate much more with patients by the internet. And for those who know her, at the right-hand side, you can see Els Brouwer, who is also for decades involved in the whole lymphedema world. And then first in 2000, we did a lot of work together with many other representatives from societies, from medical groups, from paramedical groups. And then we stated the first guideline for lymphedema. And in this guideline process already, patients are very much involved, telling about their experiences and the answers they want to have from a more scientific point of view. And the guideline was made on base of consensus. And then actually in 2005, we had the idea that we as the Expert Center want to be more independent from the network. And that was the reason that we started the, as I call it, NLNet 2.0, a new network, then independent from Drachten, working together with all other partners in the country. Importantly, patients are in the lead and working together, making a good position in guideline development, position papers, but also when we have negotiations with the government or health insurance companies. And what we did from our organization was that we gave the URL, the intellectual property and the ownership of the website to this new foundation, which was called NLNet, the Nederlands Lymphedema Network, as it is in Dutch. And nowadays the website looks like this. This is a screenshot from a few days ago. Very professional and all working together. Of course, patients, the doctors, physiotherapists, and all others involved in the problem of lymphedema, lipedema, and so on. And as you have a look what we did the last year, of course, there are groups, patients can meet each other, they can ask questions, but we organized the support groups through the country. Sorry for the typo error I see here. There was a book, as you can see, Impressed by You was the name, where patients talks about special children, but also adults talking about their lymphedema and the way they cope with the lymphedema. We have our journal twice a year. It's called Lymphologica. There's Facebook, Twitter, of social medias, of course. And NLNet is member in several other more umbrella-like organizations in the Netherlands for patient groups, for chronic diseases, for rare diseases, and so on. And last but not least, NLNet is also involved in the National Lymphedema Framework as being a national partner in the International Lymphedema Framework, the ILF. And that's also a part which is at this moment under reconstruction, and we try to involve that more than we did already. There were congresses, as I said. We have a yearly national congress most of the time, and the last one was in October this year. It was called Edema, You Don't Have It Alone. And also here you can see there were presentations, workshops presented by patients, by professionals, either doctors or physiotherapists. And well, I think a very good congress. And we have regional support group meetings, also for patients. And in 2016, we were very honored by hosting the ILF Congress in Rotterdam. In 2016, the European Network for Rare Diseases was erected. And for lymphedema, we have a working group which is covered under VASCURN, the Vascular Malformation Network. And as you can see on the right-hand side, many countries are involved, also from patient groups from Portugal, as Manuela is one of the members there. And you see the doctors coming from Netherlands, Belgium, France, Germany, Slovenia, Finland, and Denmark. And we have members after Brexit, of course. The English partners were not able to be member as a center, but now they are on a more private basis, personal basis member, because they have a very huge impact in what we do all the time. And in the future, we have contact with Spain, Poland, Hungary, and Austria. And well, in future also perhaps Portugal can be a representative. Of course, there are long lists you have to requirements you have to fulfill before becoming a member. But also at this moment we have the opportunity for affiliation memberships, which are more easy to obtain, and then also to join our sessions. And you can see here, one of the colleagues of Manuela is Eline, and she will speak after me. How did we organize it? And I think that's very important to organize a patient network from the professional point of view. There's a general board, and in our constitutions, we said how the members of the board and advisory board as well, how they have their background. There's medical doctors, there are representatives from the various medical and paramedical associations. One of the members is from the expert center in Drachten, and of course are patients involved. And they all have to be member in the general board or the advisory board to keep the quality high and to guarantee, hopefully, that it will be multidisciplinary and it's not just one group which will overflow the others. We have an expert group for lymphedema, specialists in the field of lymphedema, and we have a separate chapter for National Lymphedema Framework. And that's one at the moment is under reconstruction. How can we be, as a framework in the Netherlands, more active? And of course, there is a patients' council also involved to advise the general board in the issues important for NLNet. And at the moment, this works well. Of course, yes, we have to rely on the enthusiasm of the individual partners and persons, but that's always the case. And I think that is also in our group. So what have you learned the last, 20 years? One of the main issues is patients are really partner in the process. And it's very important to be aware that both patients, but also professionals stay in good communication with each other. The healthcare providers, they have to look after that it will be on a scientific basis and will more generalize. And patients, of course, have to look after that they will not become too focused on their own disease and then extrapolate it to the whole group. And I think the balance between both is very important. The personal talks, the personal experiences on the one hand side, and the scientific outcomes on the other side, and then come together to a good approach and a good message and products. The good organization hopefully can guarantee a little bit that we will stay independent from egos from persons, but also from certain parties. For example, not the medical doctors are in the lead, or the physiotherapists, or the patient groups. No, we all are as important in the whole organization. Of course, you really need enthusiastic and dedicated people, and I'm very happy that we have them here, but we also have them in PPL, and that's of course mandatory. Primary and secondary lymphedema are really two dedicated groups, and therefore in NLNet we have also children programs with special attention to sexuality and psychology. I think a very important thing which can also be for discussion is looking back in the last 20 years, was the good thing to include lymphedema patients in the Dutch lymphedema network. And you can look at several points to it, because patients with lymphedema and lipedema are completely different, have mentally completely different, have completely different diseases, because lipedema is actually a fat disease and has nothing to do with lymphatics, although lymphatics can be involved in fat diseases, of course. It's very difficult to cover both conditions, I think, in one organization, because when we have the Congress, in the beginning we had a special Congress for both diseases, and now we separate them so often a little bit, because the questions and the problems lipedema patients have to face are completely different to those suffering from the lymphedemas. And I think that's a very interesting question which needs discussion perhaps. And we don't have the answer, but it's just an observation from my side that at the moment in the Netherlands, lymphedema patients, especially also primary lymphedema patients, sometimes don't recognize themselves anymore in the patient group because they sometimes think that the attention is going too much to a lipedema patient, which of course has completely other way of, well, performing. And well, that's our endeavor at this moment. I want to thank you for the attention.
Thank you, Professor Damstra, for this excellent presentation, a presentation that is focused on the patient. And it is a pleasure for me to introduce Dr. Eline HoosgtraDutch. She's a project manager, and she's here because she represents the Dutch Patient Organization for Lymphedema in the European Reference Network. She also initiated the Patient Journey project, and she's going to talk about patient journey in the Netherlands. Thank you.
Thank you very much. Can everybody see my slides and me?
Yes.
Okay, perfect. Well, first of all, I would like to thank you for this great opportunity, and a special thanks to my fellow EPEC patient advocate, Manuela. So thank you. And yes, I'm very honored to present the outcome of the project, The Patient Journey for Dutch Patients with Primary Lymphedema. And first, I would like to tell you something about my journey, how I ended up here today with you in this webinar. I was diagnosed with primary lymphedema in 2013, and I started my volunteer work as a patient advocate for the Dutch Huidfonds. It's believed that in Holland, 1 million people suffer from a skin condition. So that's a lot. Taking into account there are 18 million Dutchies in the Netherlands. And in 2016, I joined NLNet, the patient organization which Damstra just shared a lot of information about with us. And in 2019, I became the Dutch EPEC patient advocate for pediatric and primary lymphedema for the European Reference Network, Vasculares. So that's a big title and also a big responsibility, because who am I? Just a Dutch patient, and how can I represent all these Dutch patients? Because I learned during the sessions with my fellow EPEC patient advocates like Manuela in Portugal, Pernil in Italy, Carina in Germany, that we all differ a lot, and also the challenges we face per country and the type of treatments differ a lot. So what is best for the Dutch patients whom I'm representing? And I have a background in online marketing and project management. And the first thing I always tell my customer is, okay, what is your target group? What's their customer journey? And then I figured, hey, I can do that. We can investigate what the patient journey is for the patients in Europe and for me in the Netherlands. So we agreed upon that we needed a patient journey. I discussed that with my fellow EPEC patient advocates and also the expert center, Nijsvellingen with Robert and Ad and other doctors, and also the NLNet board members. And we all agreed upon the project. Yes, a good idea. We should make a patient journey. But how do you start? Luckily, Eurordis, pretty familiar, I assume, with you all, already made a template. And they stated that there were 5 main phases for people with a disease. First, you have the first symptoms. Then you enter the research and testing phase, the diagnosis, the first treatment, and the follow-up care. And we use this basic template as the basis for our project. And obviously we did add some additional things because we patients believe that self-management is really important. So we also wanted to learn more about the level of self-management. We also wanted to learn more about cellulitis, because we believe it's a very nasty complication and it happens a lot to primary lymphedema patients. And we also wanted to know more about genetically testing, because very often it is combined with a syndrome. And what was the aim of this project? The aim is to identify difficulties in diagnosis, access to treatment, and self-management for patients. And how did we do that? We made this very strict template, which we discussed with the expert center and within our working group, and also doctors had a look at it and verified it. We used this template and we interviewed 35 patients by phone. I interviewed 35 Dutch patients or their parents. And we had a very interesting set of patients, which I interviewed. Here you can see some data. We had a lot of different age groups, male, female, and also you can find already some information about they were genetically tested. And what did we learn? Well, actually, I was pretty shocked about the data. On average, the first symptoms appear at the age of 13, and then people enter the research and testing phase. They often visit several doctors, but it will take, on average, 6.8 years before patients receive a correct diagnosis. And even when they enter the system, with the first system with the family doctor or the general practitioner, it often takes 11 years before they get a diagnosis. But when you're already seeing a specialist, you will often get a diagnosis within a year. So that's slightly positive. When you're already in the system, you tend to get a diagnosis sooner, earlier. But take into account, you are a patient and your feet is swollen and you go to your family doctor and it takes you 6 years knowing that something is wrong with your body before you actually get a correct diagnosis and you know what the problem is. And then you find out what the problem is. You seems to have a chronic progressive disease, and that's pretty intense to receive that message. Okay, but once you have your diagnosis, what's next? What will be your first treatment? Well, obviously, you start with the reduction phase, but we realize that also within the Netherlands and within Europe, there's a lot of discussion regarding the treatment, especially like the manual lymphatic drainage. And we did wanted to learn more about this in the Netherlands. So this is the data. 69% of the people did receive MLD after the diagnosis, and on average, they receive it for 20 years. And 23% of the people is still receiving MLD on a weekly or monthly basis. And this also shows that 97% of the people wears compression. And that's a very good thing because compression garments are essential for people with lymphedema to maintain and self-manage their lymphedema. But it also indicates that 94% of the people struggles with those compression garments. Either they just don't like it, they feel bad that they need to wear it, or they have problems with the financial resources or the prescription process or the management of fitting. So that's also something that really stood up when I interviewed the patients. But assume people have a diagnosis, it's stable, they have their nicely fitted compression garments. What's next? What's the follow-up care? Because it's a chronic progressive disease. There's no cure yet. So we wanted to learn more about the level of self-management. What do patients know and what do they actually do and apply? Those results I'm actually pretty amazed and proud of. Because if you can see here on self-management, every patient I interviewed knows it's important to wear their compression. And they are very compliant with their compression therapy. 97% of the people does wear their compression the way they are prescribed to wear them. And they all know it's important to move, to get that muscle pump activated and to improve the system going. And they know about a healthy body weight and good skincare. So actually, I was pretty amazed about this data. And we also asked questions about the cellulitis. And that data was actually, we kind of already knew it, but it confirmed what we were thinking, that 43% of the patients experienced cellulitis, and that almost 30% of the people experienced more than 10 episodes. So this does indicate that, at least for the Netherlands, it's a big, not challenge problem for patients, cellulitis. So in conclusion, we learned a lot, but mainly we learned that lymphedema has an enormous impact on the patient's quality of life, which we already heard earlier today. And patients experience many challenges throughout all the phases. But it also shows that patients have a very high level of self-management. When they are there and they have a diagnosis and they have received their first treatment, they're very compliant and very eager to maintain and self-manage their lymphedema. So please acknowledge this and provide these patients with the proper treatment, tools and compression garments for self-management. Because we lymphies are no difficult patients. We are patients in a difficult situation. And actually, we're pretty fun. And as a closure, I would like to thank you for your time and this great opportunity. And Manuela, special thanks to you. Bye.
Thank you, Eline. Thank you.
So thank you a lot for the excellent presentations to all the speakers. I'll now open the discussion panel. I'll invite everyone to write in the commentary section any question you would like us to ask the speakers. So please proceed. I'll begin with 2 questions of my own. My first question is to Eline. I find really interesting your study of the patient journey. I think that's something I would like to see in Portugal, because I think we'll get even more surprising results here in our reality. My question is, in your study, did you realize what are the main obstacles for the faster diagnosis? Well, if you think it's a problem of the patient information, if patient don't know where to go, if it's a problem in the medical organizations, did you get any details on where what's the main obstacle for a faster diagnosis of lymphedema?
Well, thank you for the question. I interviewed 35 patients and all very different stories. So it's pretty difficult to say what is the main challenge. But in general, I would say when you're already in the system or familiar, then it rather goes quickly. But the patients I interviewed that are just friendly people and a little bit insecure, are not familiar with the healthcare system. They just go to their family doctor, which is not familiar with lymphedema. And they are kind of like, okay, let's see what happens. And they tend to rely on the family doctor. And I think there is the biggest challenge, that basically the very assertive patients who really know their way around, are very savvy with internet, Google.
So you think the problem is inside the system, is not from the primary care to a specialized center? There is too much delay and not so much on the information of patients.
Yes, and we as patient group, which Manuela is also part of, obviously we try to create more awareness within the healthcare system. But on the other hand, we also believe in the power of educating patients. So we are working on websites and projects in the different countries to educate patients, because everybody has Google. So when patients go online, we could also help them with more information and the right direction which they could go in their country.
Okay, thank you. My second question is for Professor Ivone. I agree that evaluating quality of life is really important in a chronic pathology like lymphedema. My question is, practical point of view, when do you think we should assess quality of life in every visit after treatment cycles? If it will be better for a self-reporting questionnaire for the patients, or we usually have so little time for these patients, so when or who should assess the quality of life of these patients?
Thank you, Vitor. I will answer you first by giving my congratulations to Eline and maybe saying that we should do something what Eline did here in Portugal to the quality of life. When we think about what is the quality of life of our patients, we must first let the patient know what it is, the disease, for them to understand it, for them to have some adherence to the treatment, and then we can evaluate the quality of life. Because if you ask anyone who still does not understand the disease, who goes to the GP, as we can see in the Netherlands, and maybe it's even worse here in Portugal, it takes so long to have a diagnosis. You will always have a very, very bad quality of life because you can't even imagine the impact it has on the patients if there's no perspective of treatment. So first, I think we have to do is have the education part. We have to have the engagement and enrollment to the treatment. And in the end, we should evaluate the quality of life. Beginning it with not giving nothing to the patient before, maybe the results will be very, very bad, because quality of life is what I think about myself having this disease. If I don't understand it, if I go to the doctor and he doesn't know what I have, maybe we will not have a real evaluation of quality of life. Maybe we should begin, and this is a challenge to our society, to try to do something that Eline did in the Netherlands. Maybe it would be the first big step to improve these patients.
I completely agree. We need to first understand what our reality and then to make changes on that.
Yes.
Hello again. I will ask a question because I'm a doctor, I'm a surgeon, and so practical issues about the treatment of lymphedema, it's concerning me a lot. And there is a question I want to make to Professor Damstra. How do you think the treatment in the critical cases should be? In ambulatory, like we see in a lot of clinics, or in internment in the one initial phase? Do you think that the clinics and the hospitals that make those treatments with the patients in the internment, it's better or have better results than those who do the treatment ambulatory?
Thank you for the question. Well, to be honest, I think it's both. What we have in the Netherlands, we as an expert center, you cannot just come to us as a patient. You have to be referred not by your general practitioner, but actually by your medical specialist. And in the Netherlands, we have an organization which is from the government, actually, that we call it like a pyramid. So when you have just a simple, normal lymphedema, let's say, just a little bit of the arm, for example, then you can also go to your local therapist, your local doctor, to have a proper diagnosis, to exclude, of course, tumor recurrence. And then you can go to a local therapist and she can do good treatment, and that's no problem. But importantly, when you don't see a good result after 8 to 10 weeks, there's the possibility to refer a patient to an expert center. And that should be done by a medical specialist. Therefore, we see about 500-600 new patients a year, but they're all just the top of the pyramid, to be honest, because those are the patients which are unclear in terms of diagnosis, don't react properly to the treatment. And I think that's very important for patients. When you start your treatment locally, just have a revision after 6 or 12 weeks, including, of course, quality of life. And when you don't see a good result in terms of volume reduction, in terms of improvement of your mobility, your quality of life improvement, then perhaps you have to rethink your diagnosis or rethink your therapy. And then, of course, there's the option to go to an expert center or go to a more a clinical in-ward treatment for a patient. And what we do, we have both conservative treatment, but also operative treatment for lymphedema. We do a lot of reduction surgery as well, because we see a lot of end-stage patients. And that's perhaps also what we have in the cooperation together with patients organizations, that we start early diagnosing and early treatment, because they can provide, of course, that you have the later stages of irreversible changes and the real stage 3 lymphedemas. I think that's very important. And perhaps I can take the opportunity, as Eline already told, the discussion we have in Netherlands and we have in Europe overall, it's the location and the importance of MLD. And as you see, the patients who got MLD in our country as well, it was for 10 years. But in our guideline, we say, well, after 12 weeks, you have to stop your initial treatment phase and you go into the maintenance phase. And one of the recommendations we have in our guideline is that we think that in the maintenance phase, there's no place for MLD whatsoever. So that's very strict, I recognize, but I think that's very important. So in the initial treatment phase, you have to do a lot of things. Self-management is an important one of it, compression, of course, but also empower the patient in doing things themselves. And a proper follow-up, of course, is also mandatory. I hope that this answers your question a little bit.
Yes, thank you very much for your answer. Now I think it's the time for Joana, isn't it?
Hello, yes. This is the last question. I talk a lot with Manuela, and one information I got from her is that in Portugal, when we compare with the Europe, mainly with Netherlands, the patients are not so involved in the medical decision. There is like a gap between the medical decision, the doctors, and the patients in Portugal when we compare with other countries or with other countries, even with Netherlands. So I would like to ask for all the panel what they think we should do to involve the patients in the medical decisions.
I can start, maybe. I'm in Portugal. I think we have a culture problem in Portugal. We have to change that first. It's not only regarding lymphedema, it's regarding any disease. It is important for the patient to know that what used to be, and I'm going to use a very typical Portuguese cultural expression, it is the doctor is God and God decides what you have to do. So this doesn't happen any longer. So we have to have a dialogue between patients and doctors. We have to have a big education program, which we don't have in Portugal. I think that is the big gap which we have regarding any disease, so that the patient has a good literacy about what is a disease, and then we can have a good workout for patients and doctors. So the gap which you're talking about, Joana, exists, but first we have to do something to change our cultural way of staying, which is, I don't have to worry about my disease, someone is going to solve it for myself. And we know it happens a lot. So we have to have more engagement of the patients, and that is where the associations, the patient associations, really have an important role to bring patients together, for them to understand them, and then to have this close workup with the doctors.
Thank you. I would like to also hear Damstra and Eline, if they don't mind.
Yes. Well, I agree with you. I come often in Germany, and then you have the same problem. What do we have here? You have, of course, internationally, we've got the ICF method, which has a more holistic approach, and you have a very nice overview of the quality of life, with also a lot of many of them are ECF based. I think that's the first thing. Lymphedema is not just a medical problem, but there are many, many aspects in participation activities, the psychological part, the wishes of the patient, of course. So clinical reasoning, deciding together is so important to have a good help to the patient, and especially in chronic diseases. Of course, when you have cancer or you have an accident, it will be clear you have to be operated. But in chronic diseases, it's completely different. You are actually both partners. I think that's the first step. We have the chronic care management system coming from California, from the Wagner group, for example. And we incorporate already in our first guideline in 2000, which looks at, as I said, the pyramid. So when there are really big problems, then you can go to an expert center. But most of a patient in the maintenance phase, up to 80%, is very able to do self-management. As a lot of Eline told already. And of course, there's a small group who are not able, don't have the illiteracy to help themselves. And of course, they can stay under control by a paramedical or by another. But I think you don't have to underestimate your patients. They are very active and really, especially lymphedema, willing to do things themselves. And perhaps I have time to stretch out the points of study done during the Corona time by the people, the patient advocacies about the lymph drainage, for example, in Europe, because due to Corona, there was no possibility to continue the treatments by the healthcare providers. And what we saw was that the patients in countries who have a lot of, dependency to a healthcare provider are much more sad and unhappy than those who are able to perform, for example, self-management as the patients were in the Netherlands. And that's, of course, very interesting, but not due to Corona, but really, I think it's very important also to have possibility to, in terms of finance of the whole system. I think those who need treatment, of course, they do have all opportunities to go to a center, but you have to try to train your patients to be more independent from the healthcare provider, and they really can have the trust in your patients. And therefore, self-management sometimes, they think, you have to do it yourself, and therefore sometimes you use the term together management. It's not to yourself, you do together because you have the opportunity to go back to your healthcare providers. And electronically, very interesting, we have a way, we call it the Beter Dichtbij app, the Better Close By app. It's a kind of WhatsApp system. So you're always able to contact on a very low profile basis your center if you have some questions or whatsoever. So I think we don't let them swim because that's often what they think. No, we don't do that. But you are trying to make them more self-management. And I think Eline can tell much more about that.
You teach the patients how to swim. So no, that's correct. Maybe if I can add something, I think the most important thing I learned also from the interviews, that I'm a patient, I have my own box and my own way of working, but I realized that every patient has different needs and different concerns. I mean, I spoke to a young woman in her 20s, and she was really embarrassed about her boyfriend and the sexuality and everything. But I also spoke to a woman who was very worried about getting pregnant and her lymphedema. So I think in all scenarios, I think as a healthcare provider, it's good to ask, okay, what is your main concern? Because obviously as a doctor, you would like to fix as much as you can, possibly, but maybe it's not the leg being swollen. Obviously, that's an inconvenience to all patients, but maybe the thing the person struggles most with is just feeling ugly or being scared that when she gets pregnant, her baby might have the same chronic lymphedema. So I think the thing I most learned, I think, is just have an open discussion, what the patient actually needs and what's their biggest fear, challenge. And then team up and do it. Because I think for Holland, self-management, I strongly believe in it. So, yes.
Okay, thank you very much. So I think Manuela can close the section.
Hello. First of all, I have to thank you very much. This challenge that Eline is talking about, and also Dr. Ivone is talking about, in Portugal, we have a very huge problem. We don't know where we are. We don't know each time we speak with the doctor, they don't know exactly where we are, because lymphedema in Portugal is not so well known as it is in Holland, for sure. And we try to do the patient journey. We tried, but it's not easy at all. Also because of RGPD, and that's one of our main goals, is to do it, but it's not so difficult. Maybe now, with your help, we can do it. That will be very nice. That's a challenge for you, Ivone, and also for you, Joana and Vitor. So thank you to all of you that are also on the other side of the screen. We can back again for, I hope you like to enjoy. I know that I have some question on the chat, but the time is running and we can answer later on. And for today, it's done. Thank you very much. And don't be in tune, because next it will be Netherlands, after Netherlands, sorry, it will be Denmark for these lymphedema sharing points. And next Monday, just go to the lymphedema in lower limbs with Vitor and also the podologist João Vieira. See you.
Thank you.